Yes, Asa, you are muted. Please unmute. Asa, you are muted.
Thank you, sir. Thank you. Now I would like to welcome Dr. Preeti Kumar, ma'am. This is her family that is here. And she doesn't need a very big introduction, but she is the Maternal and Perinatal Committee, SAFOG chairperson, Safe Motherhood Committee, FOXY chairperson, just gave up, and Joint Secretary, India Gestosis Chapter, committee member of MFM Committee, AOFOG. And more importantly, she is seeking blessings and support for BP North Zone election this year. So, over to you, Dr. Preeti, for your comments about this program.
Thank you, Dr. Asha. Thank you for the warm introduction and promoting my candidature for the post of VP, though it's a little unofficial on any academic platform. But thank you, Dr. MC Patel, sir. I think I'm always the crucial part of all the happy webinar series that you conduct in Lucknow and in UP, of course. So when we were discussing about this webinar, I did talk to Madam also, and she suggested that we should have this topic on assisted vaginal birth, because when we look at the maternal mortality of a country, it's anemia, PPH, and increasing cesarean sections. These are the three major concerns of a country. So we thought we should, do something which is either decrease the cesarean section rates and increase the vaginal birth. So we have learned, all the seniors here, sir, all the gems of Lucknow are here on this platform today. My teachers, all Dr. Chandravati Madam, Dr. S.P. Jaswal, Dr. Yashodhara Pradeep, Dr. Manju Shukla, all teachers are here, all seniors, Dr. Geeta Khanna, Dr. Rajul Tyagi, all dealing with high load. They have high delivery load. Even Neelam is here. Amita, they have vast experience in vaginal birth, and they are doing daily almost hundreds of deliveries in their facilities in a month, more than that. So we will have good interaction on this platform, and a very, very whom we admire, Dr. Anju Goel, would be speaking on assisted vaginal birth. She's the best speaker from Lucknow, and everybody looks forward to listen to her. So thank you so much, sir, for giving us the opportunity to conduct this happy webinar series. And from Lucknow Society, we wish you all the best for your candidature of president's post. And we know the kind of work you have done for the organization, the kind of connect you have with the people, or with all the members of Foxy. I admire you very closely. I watch you very closely. You have good relationship and you try to maintain that. So thank you so much, sir. Thank you for making me part of this webinar series. And I'm really thankful to our Dr. Asha, because she called me just now. She said, Dr. Preeti, you should put your PPT here for the election also. So that's a kind gesture on your part, Dr. Asha. And of course, Dr. Rekha, who is also very close to me from Bangalore. So thank you once again, sir, for this opportunity. Thank you, sir.
Thank you. Thank you, Preeti, for sparing time for all this webinar, not for execution, but from beginning also. I would like to say something about Preeti. She just completed her tenure as a chairperson of Safe Motherhood Committee. And what tremendous work she has done under that very committee. And she had put that very committee at so much big height that her follower will have to do very heavy work to reach that level which Preeti has done. She has traveled a lot across country and even outside country also, because in Sri Lanka also she was invited to conduct a workshop relating to Safe Motherhood Committee. So, and I have also joined in few of her program, and I have observed him working very minutely and very closely rather, and training our subordinate staff, our staff sisters and other staff, because in many times in an emergency, first person to deal with patient is our staff, and how to deal with in those very emergency to take utmost care of patient till a doctor comes to rescue the patient. So she has taken that very area as far as training part is concerned to a bigger height. So many congratulations for the same, Preeti, and you are very deserving candidate as far as post of Vice President North Zone is concerned.
Thank
And
you so much, sir.
my
Thank you for your
all
kind
the
words.
best wishes to get it done. And
Yeah, thank you so much, sir. But I give my credit to all my teachers and all the team members,
yes,
rather,
yes.
and all the
Of course, you had
facilities.
good team,
Yeah,
but
thank
of
you. So
course, under your able leadership only, your team or your committee could do this. I
yes, sir.
should
Thank you so
frankly
much, sir.
admit.
Thank you so much, sir.
Yes.
Thank you.
Thank you, Dr. Preeti, and thank you, MC sir. I would like to give a brief introduction of the second coordinator, Dr. Rekha Rajendra Kumar ma'am. She's a practicing gynecologist for 31 years, and she's the president of Bangalore Obstetric Gynec Society. She's an IVF person, a very warm human being, and a very good dancer. So I'm actually giving really short introductions so that we have more times for academics. Welcome, Dr. Rekha. Now, I invite Preeti ma'am to introduce our chief guest, another person who needs absolutely no introduction. I've been knowing her for personally, even I'm not in Lucknow for 24 years. So, over to you, Dr. Preeti, to introduce ma'am.
Thank you so much, Dr. Asha, for giving me this opportunity. I would rather not read out this CV, what you have displayed. Just want to express here that whatever I am today is because of Dr. Chandravati madam. She has served the institution KGMC as professor and head. I think so many students passed out and they still, look at to her for, she's an ideal for us, a living legend of Lucknow Obs and Gynae Society, and we really have a lot of respect for her. She has served as at the highest post of several organizations like IMA, even RC, all even the logs as a president. Then she has served vice president, even Foxy. And just happy to share here that we had put this request from Foxy that we wish to start the Professor Chandravati Family Welfare Symposium in Foxy in the zonal conferences. And I'm happy that Dr. Yashodhara Pradeep madam was also there as a vice president, and she also endorsed that, and we really got it approved in the GBM. So from henceforth, we will be conducting Professor Chandravati Family Welfare Symposium in all the zonal conferences. A very warm person, all kind of adjectives if I use would be less, a motherly figure for all of us in Lucknow society. And thank you, madam. Your blessings are really very important for us. And thank you for everything. Thank you, ma'am.
Over to you, Chandravati ma'am. Please, ma'am, please unmute yourself. You are muted.
Sorry. I got so excited that I sort of muted myself. So much adjectives from MC Patel, from Asha, you and Preeti. Everyone has put me on this very, very high pedestal for which I think it is not a very deserving thing, because I don't feel like a guest. I feel like a host for this MC Patel's all the academic performances. I've been there, so I would not be a guest. I would like to be a chief host for the webinar today. And thank you, MC. You have chosen smaller societies, and you've chosen to bring them together. It is such a wonderful way of conducting this workshop and involving these smaller societies, because then they feel updated and they come to the normal academics learning for all the members of the society. The subject you have chosen today, I think, is a super subject, but with a very guarded thing, because with the slightest this side, that side, one is caught into medical legal problems. So one has to be very, very careful about assisted births and inductions, and when to stop, when to do cesarean, when not to do cesarean. All those yes and no's are there, and I'm sure Anju is going to discuss all that. And then you have wonderful panel, all this expert panelists with your moderation. I'm sure they are going to really give justice to the subject. I wish this webinar a great success. I will be there. I will be hearing Anju's talk also, and I will be listening to your panel also, and wish you a success, not in this your happy learning webinars, but what you are really looking for. You and Preeti and everyone, I wish all the success in their future. Preeti's success would be my success. So if she wins, I think I will win the this vice president's post once again in life. And MC, I'm sure if you win as a president, I think it will be a great party we will have in Ahmedabad
Yes,
when
exactly.
you are there.
Always
Ma'am,
welcome.
I'll go for food drug committee. Please bless
वो
me.
तुम्हारा तो पक्का है यार, तुम्हारा ड्रग कमेटी तो पक्का। आशा, छोटी सी चीज के लिए क्या कहना, तुम तो 100% ही हो। तुमने आज सुबह ही बताया था मेरे को। So I wish you all the success, all three of you, and wish this seminar a great success today. Thank you.
Thank you. Thank you, Chandravati Madam, for sparing time. Just I mentioned prior also, you are always with us in any of our academic activity. We are always blessed by your blessings. Thank you, madam.
Thank you. Thank you, sir. Dr. Rekha,
Yeah, I'm there.
would you please introduce
Yeah.
Yashodhara ma'am?
Thank you, Dr. Asha, for a warm introduction on me. I'm very happy to share the platform with many of my friends here. Dr. Preeti is my close friend. The day when we were in the managing committee meeting of AICOG Hyderabad, I was really astonished to see the amount of work what sir has told now. I totally endorse that. The amount of work what she has done is really unimaginable. I really don't know how to work so much. Not only that, the mask, she has taken the entire mask forward. That is a sign of a true leader. Preeti, you are really an achiever and a leader. I totally appreciate you on that. Now it's my noble task and a great privilege to introduce Madam Dr. Yashodhara Pradeep. I happened to meet Madam also that day. Madam is a Vice President of FOXY 2022 to 23, Professor, Head of Obstetrics Gynecology Department of Lucknow Medical College. She's a Senior Professor in KGM University, Professor of ELMCH, Chief. Can I have Madam CV? Yeah, she's been president of Lucknow Society, Obstetric Gynec Society, as well as Menopause Society, vice president of IMS Society, and she has also been awarded the Best Paper Award from FOXY in 2012. We are so happy to have you, madam, here. Your august presence means a lot to us. We would like to hear your words of blessings. Over to Dr. Yashodhara Pradeep, madam.
Ma'am, you're muted.
Yashodhara,
Yashodhara,
please unmute.
Because there was some
Yeah.
conversation in the family going on.
Yes.
Right.
So, good evening, everyone. First of all, I would like to congratulate Dr. MC Patel, who is been doing 176th edition of the Happy Learning. That's in itself is a big achievement, sir. Your perseverance, your dedication is really. I still remember the first time when I was a secretary of Lucknow OB-GYN Society, and you came. And since then, we are having the association, and your presentation was excellent. And thank you, Dr. Rajen. I was muted when I said this, that I'm thankful to you for your kind words. Yes, really to accommodate everybody. So with the societies like Muradabad, Hapur, Saharanpur, and Lucknow, these are the 4 societies, Faizabad. 5 societies are here. They are president and secretaries. So I would just like to quickly take the name of people who are as a panelist, as a chairperson, as a speaker. They're all very learned. They do not need any appreciation from my side, but it is for my own sake I am taking their name. They are all very learned people. So from the Muradabad, there is a president, Dr. Manisha Jain, secretary, Dr. Dipali Verma, and there was a Professor Kanchan Prasad she's a professor in TMMC and PC, and Dr. Saba Asad. She's a past president. I had quite a few time I have talked to her. Every time when she has invited me, I am so sorry, Saba, that I could not join your society. From the Saharanpur, there is a Dr. Megha Gupta. She's a secretary, and she's a Dr. Nutan Upadhyay. I have visited your society, and I know Saharanpur society is a great society. From the Hapur, Dr. Neeta Sharma and Dr. Deep Shikha Goel, they are president and secretaries. And from my own Lucknow, from the Faizabad is a Dr. Uma Sharma and Dr. Manjusha Pandey. Dr. Uma Sharma, probably I did not meet personally because I have been to Faizabad quite a few times, but I could not meet you personally. I don't remember that. So it's a great thing that you are here. From the Lucknow, my own society, Lucknow OBGYN Society, the president, Dr. S.P. Jaiswal, Dr. Nisha Singh, Dr. Secretary, Dr. Nisha, past Secretary, Dr. Nisha Singh, and Dr. Rajul Tyagi. She's a excellent IVF person. Dr. Amita Pandey, very, very academic person. And Dr. Neelam Mishra from the Varsh Clinic, Dr. Geeta Khanna, doctor from renowned, and she's a vice president of Indian Fertility Society also. Dr. Nidhi Johari, Dr. Amita Pandey, as I have already said, and Anju, there's no words to her. She's a real academician. I would like to have an honor and privilege to be with Dr. Manju Shukla, who is a past president of the Lucknow OBGYN Society, and this is my proud privilege to be guest of honor with her. Chandra ji, no words. She is my teacher, always guide, and she always guided us. She has always taught us and how to do the things we have all learned directly from her. Preeti is there. Yes, Preeti is coming for the very coveted post of Foxy, vice president. So, but I will not say that because this is not, as the Preeti has already said, that this is not the place where we can say that all these things, because we all know each other. There's hardly any people who probably there who do not know us. Asha, my best wishes to you, my best wishes to Preeti. And Dr. Shekhar, you are also coming for some post? Are you coming?
No, Rekha not this year.
Rekha is.
Madam
Rekha.
asked me, you heard it as Shikha. No, I am not coming this time, madam. Next year.
Okay.
Thank you.
Good. You will.
Thank
You are like Dr. N.C. Patel. Have a very good ground. So each of you as well. And
Thank
my
you.
best wishes to you, Dr. Patel.
Thank you.
And I'm really thankful that you have called me again on this platform for the Happy Learning updates. So this is really nice. And the topic of the assisted vaginal birth is really wonderful. Thank you so much for making me a guest of honor for this conference.
Thank you. Thank you, Asudra Madam, for sparing time. Of course, you are always with us in any of our academic activity. Thank you. Thank you very much.
Thank you, sir. It was my mistake. I should have taken Manju ma'am first. She's a senior, but sorry, ma'am. She is a retired professor and HOD, obstetric gynae, CIM-CSH Lucknow, president of UPCOG, president Lucknow Obstetric Gynec Society, chief editor, Journal of UPCOG, and president, Association of Private Gynecologists of Lucknow. What is not written here is much more immense, that she is a teacher and has been teaching all of us. So, ma'am, I'm sorry and welcome. And we would like to hear your words of blessing, and you're muted.
Madam, please unmute
You're
yourself.
muted, ma'am. Ma'am, you're still muted. See, I've asked you to unmute, so click on that. You'll be unmuted.
Left down button, madam.
Ma'am, on your photo, next to your name, there is a mic. On your photo, there is a mic. Please touch this mic, ma'am. Tirth, can you help her, please?
Ma'am, I cannot able to unmute her from here.
Yeah,
She has to unmute.
exactly. Madam, you can speak from your phone also. Keep this on, the video, the audio part, you speak from the phone if you are not able to do this.
मैडम फोन से कनेक्ट हो जाइए, फोन से कनेक्ट हो जाइए. आई एम सेंडिंग यू द लिंक.
She is seen.
Ma'am, I've already sent her the link.
ओके, तो मैम फोन से कनेक्ट होइए.
But in the beginning, she was audible also. She was visible, audible both.
ओके,
Something went wrong.
जस्ट होल्ड.
Without the link also, she can speak, no, on phone now. Just
No,
like
no,
that?
no,
Not
no, no,
possible?
it will not be visible. No, no, it will not be audible
Okay.
unless she joins from the phone. आ गया, अब हो जाएगा.
No, like voice recording जैसे कर सकती है ना, without joining?
हाँ.
I think that's possible. Just talking so that we hear her through her phone.
But here it is seen still. She,
आ गया
हाँ, मैडम आ गया.
welcome. Welcome.
एक्चुअली हर बार ये होता है कि जब मेरा बोलने का टाइम आता है तो कुछ ना कुछ हमारे इसमें हो जाता है. अच्छा, गुड इवनिंग एवरीवन एंड डॉक्टर पटेल, congratulations for making learning happy, because studying and teaching all are very painful things in student life, but you have made it happy. So congratulations. And this is 176th edition of your happy learning. So what work you have done, and you have united so many societies in your umbrella, under your umbrella. Very nice thing. And this time I'm not going to take name of everyone. I know everyone, and they all are doing so great job that your happy learning session will be extremely educative, and we will learn many things from this edition of yours. And Preeti, best of luck. You will be there. And Dr. Patel, all the best.
Thank you.
Try and try till you succeed वाली बात होती है वैसे तो, and you are trying from long. So, all the best. And I will not take much time because I'm in this net job. I'm not very this thing. So, अब क्या हो गया? Thank you for making me part of this webinar. Thank you.
Thank you.
And all the best. All
Thank
the
you,
best.
madam, for sparing time. Of course, you are always with us in a very light and humorous way. Always, I have whenever I have met you, and you are known
Yes.
for that. And your mere presence is enough for us to inspire us for any of our academic activity, and you have spare time to bless us. So thank you very much.
Thank you. Thank you, sir. Thank you.
Thank you, sir. With your permission, we would start the academic session.
Yes, we can.
So thank you. Thank you for attending the inaugural ceremony and blessing us with kind words. Now, I would like to start the academic session. I would introduce the first chairperson. Dr. Rekha, you do the next two. And then the chairpersons will take over and introduce the speaker. So I would like to introduce Dr. S.P. Jaiswar ma'am, a very respected senior. She has MS Signature Award 2023, Outstanding Faculty 2023, Hall of Fame 22. Means you can just have a look at it. It's just full of awards and memberships. She is also a visiting professor at BP Koirala Institute of Health Sciences, Dharan, Nepal, visiting professor for ICOG, visiting professorship for the year 2020, has more than 100 publications and is an invited guest faculty and has given multiple lectures everywhere. So she's a very highly decorated person, and I invite her to be the chairperson for this session on assisted birth. Dr. Rekha, would you take over? And please
Yeah.
be really
Yeah.
short.
Yeah. Thank you, Dr. Asha, for the opportunity. Dr. Professor Nisha Singh, also my close friend. Welcome, Dr. Nisha. She has lot of important positions which she has occupied in the past. The unit head and in charge of Genital Cancer Control Unit, King George Medical University in Lucknow. Vice President of Gynec-Onco Society of India and Lucknow OBG Society, as well as UP State Chapter of AOG. And lot of vast experience she has got and arranged lot of conferences and journal reviewer, guest speaker in more than 250 national and international conferences. Thank you, Dr. Nisha, for joining us as well as chairing the session. And now it's my proud privilege to introduce another chairperson, Dr. Geetha Khanna. Yeah, Madam Dr. Geetha Khanna is the scientific director of the ART unit and high risk pregnancy and endoscopy unit in an Ajanta hospital in Lucknow. She's a scientific director there, and she's currently the vice president of IFS UP chapter 2022 to 24. Lots of awards and recognition, highly decorated CV, lot of contributions, truly an academic person. We are very happy and grateful to both of you, other than the first chairperson, that is Dr. S.P. Jaiswar. Now, requesting all the three chairpersons to chair the session and take the proceedings and introduce the speaker as well as the topic. Thank you.
Thank you so much, Dr. Rekha and Dr. Asha, for my nice, kind introduction. And thank you, Dr. M.C. Patel, for making me part of this webinar. And you are doing so much work on this. My best wishes to you and my best wishes to Dr. Preeti as well as Dr. Asha. I know they are the future of this society or this FOGSI. So thank you so much for making part of this. And the subject which you have chosen, this is very important, assisted vaginal birth. We know by day-to-day life, the vaginal birth itself is going down. And this situation, because we ask the patient for the vaginal delivery, they always say, no, do the cesarean section. We don't want to tolerate the pain and so many things. But definitely because of this increasing incidence of cesarean section, that there is an increased rate of so many complications like placenta previa, percreta, and in our department, we are facing these problems in our day-to-day life. So the topic is very good, especially in vaginal birth, which is in the form of assisted vaginal delivery. And I'm happy to introduce Dr. Anju Agrawal. She is one of my colleagues. She is a very academician person, and she's a professor and unit head and in the our medical college, KGMU, Lucknow. And she has lots of presentation, award, paper, and she is a member of many society. So she will, I don't want to take much time. Everybody knows Dr. Anju also. And I invite Dr. Anju to start her talk.
Thank you so much, ma'am, for the kind invitation. and a very good evening to all my respected chairpersons, my teachers, my seniors and friends. And at the outset, yes, I would like to wish all the best to Dr. Patel, dear Preeti, and Dr. Asha. So best wishes to all of you. Is my screen visible?
Yes.
So, as Dr. Jaswar has already introduced, assisted vaginal delivery is a very important.
Anju, your voice
Yes,
is
ma'am.
little lower.
Okay,
Huh.
so I'll speak a little louder.
Come near to speaker.
Ha. So, assisted vaginal delivery is a very important topic. And as we all know, the second stage of labor is the most dangerous for the fetus, and potentially it may be associated with serious complications for the mother also. And operative vaginal delivery, I will be focusing mainly on operative vaginal delivery in this session, has been maligned since the days of W.J. Little, when the word forceps came to becoming synonymous with birth injury and cerebral palsy. But this is not really so. A few incidences result in it going into disrepute. So, assisted vaginal delivery, we know, may be associated with problems like subgaleal hematoma, intracranial hemorrhage, skull fracture, spinal cord injury, and in some cases, it may lead to perinatal mortality. But despite this, we must remember that all of these complications are rare and mainly associated with mid-pelvic and rotational deliveries. And the other thing which we really need to remember and consider is that the second stage cesarean is also not a very easy job. It may be very challenging and may result in significant maternal and perinatal morbidity and occasionally even mortality. So when we look at some of the special situation in our country, as per NFHS 4, only 67.8% deliveries are institutional. So women who have undergone a second stage cesarean, we can never be sure they'll be coming back for an institutional delivery in the next pregnancy. And these are the women who are more likely to have an extension of the incision in the upper segment or even a T-incision, which again many times is not reported in the discharge card. So they are more likely to have rupture. And I think all of us must have observed the increasing trend of scar dehiscence in our country, which was not very common when we were residents, but now it is very, very common, especially in UP. The other important aspect is WHO lists assisted vaginal delivery as a signal function in basic emergency obstetric care. So we cannot just ignore it and do away with it. But still, we see that the use of assisted vaginal delivery is declining worldwide. USA, only 5 to 6% deliveries are by AVD. In UK, they are doing a little better, 14 to 15%. And in India, we have a meager 2 to 3% deliveries by assisted vaginal delivery. So, are there any methods by which we can ensure a spontaneous delivery and avoid the assisted vaginal delivery? It has been seen that the incidence increases with epidural analgesia, but it is not affected by early initiation of epidural analgesia or discontinuation during pushing. So it is not as if we don't give epidural analgesia, we are helping the patient. The patient tends to become exhausted if we are not giving her adequate analgesia. Nor does it benefit us if we start it late or we discontinue it in the second stage. So if we are giving analgesia, we should give it wholeheartedly rather than half-heartedly. An intervention which has been found to be effective is adoption of the upright or lateral position in the second stage has been found to reduce the incidence of assisted vaginal delivery. It has been found to promote spontaneous delivery. There is absolutely no role of prophylactic manual rotation in the second stage of labor, nor is there any role of routine oxytocin augmentation to promote spontaneous delivery. So the only aspects where we can help the patient to reduce assisted vaginal delivery is by avoiding lithotomy position as much as possible, helping her to ambulate during labor, and giving her a birth companion, all components of respectful maternity care. So when we look at the indications of assisted vaginal delivery, they may be fetal or maternal. In fetal indications, it is suspected fetal compromise, either a pathological cardiotocography, abnormal fetal blood sampling, or thick meconium. For maternal, in nulliparous women, lack of continuing progress for 3 hours, total of active and passive second stage with regional analgesia, or 2 hours without regional analgesia is considered as prolonged second stage, and many times instrumentation is advocated. But again, most of the guidelines, they say as long as a maternal and fetal condition is reassuring, we may allow the woman a little more time. Similarly, in Paris women, the time limits are 2 hours with the regional analgesia and 1 hour without. But again, the same rider holds true that as long as the maternal and fetal condition is reassuring, we can give them a little time. Then maternal exhaustion or maternal distress is an indication of instrumentation, and medical indications to avoid the Valsalva maneuver like heart disease, eclampsia, they are again indications of instrumental vaginal delivery. We may classify the instrumental delivery as outlet, low, or mid cavity. Outlet is when the fetal scalp is visible without separating the labia and the fetal skull has reached the perineum. Low is when the fetal skull is at station plus 2 centimeters or below, but not on the perineum. It may be with complete rotation or incomplete. Mid cavity is when the fetal head is no more than 1/5 palpable per abdomen. But the important thing is that nowadays mid cavity delivery is not advised. There are certain special situations which we should keep in mind. There are cases of suspected fetal bleeding disorders or predisposition to fracture, which are relative contraindications to instrumental delivery. It is important to remember that blood-borne viral infections like hepatitis B, HIV are not absolute contraindications to assisted vaginal delivery. We need to individualize. Vacuum extraction is not contraindicated following fetal blood sampling procedure or application of fetal scalp electrode. We only need to avoid vacuum delivery in cases where the gestation is less than 32 weeks and use with caution between 32 and 36 weeks. Beyond 36 weeks, it can be safely used. It is important to make the procedure safe by doing a good pre-procedure assessment. We must ensure that all the prerequisites are fulfilled. And most important is, we cannot just rely on the vaginal examination for assessing the level of the head. The abdominal examination is mandatory, and head should not be palpable abdominally before we apply faucets or vacuum. Informed consent must be taken. It may be oral, but it should be documented in the case records. It has been seen that ultrasound assessment of the fetal head position is useful in cases where the clinical examination leads to some confusion. There is insufficient evidence to recommend the routine use of abdominal or perineal ultrasound for assessment of the station, flexion, and descent of the fetal head. Except for outlet forceps, all other forceps or vacuum deliveries where the head is at a higher station should be performed in the OT with full preparation for cesarean section if required. So that is a very important rider which we must all remember. Another thing which over time is getting diluted, we must use a correct instrument. For the outlet delivery, we need to use a short curved or a Wrigley's forceps. But for all other deliveries like the low forceps, abnormal presentation like occipito-posterior, breech after coming head of breech, we need to use the long curved forceps, the prototype of which is available in our institute is Haig Ferguson, but it may be any other, but it needs to be a long curved forceps. So these are some pics of the same. To remember the steps of forceps application, we have the alphabet mnemonic, which makes it easy to remember. A is for assistance and anesthesia. Bladder must be empty. Cervix should be fully dilated and membrane should be ruptured. We must determine the position of the head, check the equipment, apply the forceps, give gentle traction. The important word here is gentle. We should not put all our weight on the forceps and not give too much of traction. Hand elevation, incision or episiotomy if required, and remove the forceps when the jaw is visible. Similarly, for ventouse, we have the same mnemonic. Everything is same. For F, we have fontanelle check to place a cup. Again, gentle traction is very important. We must halt in between contractions, or if there are more than 3 pulls, or if there are more than 2 pop-offs. Again, incision or episiotomy if required, and remove the vacuum when the jaw is visible. Analgesia is very important when we are performing an instrumental vaginal delivery. For the low or outlet deliveries, perineal block may be adequate, but for mid-pelvic or rotational delivery, regional block is required. We may substitute it with a pudendal block. But again, mid-pelvic and rotational deliveries are usually not recommended in modern obstetrics. Now, which one to use, forceps or ventouse? We need to use the instrument appropriate to clinical situation. For example, if the baby is preterm, we will prefer to use forceps. Another very important consideration is the operator expertise. Whichever instrument the operator is comfortable with is the better instrument for that case. But when we compare the two, we know ventouse is more likely to fail as compared to forceps. It is more likely to be associated with cephalhematoma, with retinal hemorrhage, and maternal worries about the baby. But it is less likely to be associated with significant perineal and vaginal trauma, which is more with forceps. And there is no difference in the odds of cesarean section, low 5-minute Apgar, and need of phototherapy between the two techniques. Also, the soft cup vacuum extractors have a higher rate of failure, but a lower incidence of neonatal scalp trauma as compared to the metallic cups. The most important thing, as Dr. Chandravati ma'am was also saying, we must know when to stop. We cannot just go make it an ego issue that yes, I have to deliver this patient by forceps or ventouse, whatever we are doing. We have to know when we need to stop. So for ventouse, we need to stop if there's no evidence of progressive descent with moderate traction during each pull of a correctly applied instrument. Complete vacuum assisted birth in the majority of cases with a maximum of 3 pulls to bring the fetal head onto the perineum. If the head has come on the perineum, you may give 3 additional gentle pulls. Again, remember the emphasis on the word gentle pulls to ease the head out of the perineum. If there's minimal descent with the first 2 pulls, we must reevaluate, and we have to discontinue Ventouse if there have been 2 pop-offs of the instrument. We must remember that the rapid negative pressure application for vacuum-assisted birth is recommended as it reduces the duration of the procedure with no difference in maternal and neonatal outcomes. This again is an important point because previously, because of the slow buildup of pressure, vacuum was not recommended for cases of fetal distress. Now it is not so. Is there any role of sequential assisted vaginal delivery? Very limited, because it is associated with an increased risk of trauma to the baby and increased risk of obstetric anal sphincter injury following sequential use of instruments. That is, forceps after a ventouse or a ventouse after a failed forceps. So it is better if we are discontinuing, we move on to a cesarean section. So when do we stop using forceps? We must discontinue if the forceps cannot be applied easily. We do not need to use force, or the handles do not approximate easily, or if there is a lack of progressive descent with moderate traction. Also, we discontinue if birth is not imminent following 3 pulls of a correctly applied instrument. Re-evaluate if there's minimal descent with the first 1 or 2 pulls of the forceps. Discontinue rotational forceps birth if rotation is not easily achieved with gentle pressure. Again, the word gentle is very important over here. So whatever it may be, forceps or ventouse, we have to know that we apply only gentle traction. Like for forceps, we apply traction only whatever we can apply with the forearms. We should not extend our arms and apply excessive force. What are the cases where we are more likely to fail? Women with high BMI, greater than 30, short women, where the estimated fetal weight is 4 kg or a clinically big baby, or the head circumference is above the 95th percentile, that is where cephalopelvic disproportion is more likely, occipito-posterior position, or when we are attempting a higher level forceps like mid-pelvic birth, and at least 1/5 of the head is palpable per abdomen. Anything more than 1/5 palpable per abdomen is not at all acceptable for application of forceps. And ideal is, if the head is at all palpable per abdomen, forceps should not be applied. When we are doing a cesarean following an failed assisted vaginal delivery, we need to remember there is an increased risk of neonatal morbidity. There is an increased risk of fetal head impaction. So delivery of the head is difficult. So we need to be efficient in other techniques like Patwardhan or delivering the baby as breech. Suppression of contractions should be considered while preparing for cesarean delivery, especially where the decision to delivery time may be delayed. Now, what about episiotomy? Traditionally, we have always been applying episiotomy in all cases of instrumental delivery. But with the advent of restrictive episiotomy, we need to relocate even in cases of assisted vaginal delivery. And guidelines say that there's no robust evidence to support routine or restrictive use of episiotomy at assisted vaginal birth. The decision should be tailored to the circumstances at the time and the preferences of the woman. The evidence to support mediolateral episiotomy in all cases in terms of preventing obstetric anal sphincter injury is stronger for nulliparous women and for birth via forceps. And remember, when doing the mediolateral episiotomy, the cut should be at a 60-degree angle initiated when the head is distending the perineum. So episiotomy is never to be given prior to application of the forceps or ventouse, and it is only to be given when we are sure, yes, we are going to be successful, we are getting descent with our initial pulse, and the head is distending the perineum. Prophylactic antibiotics are recommended. A single prophylactic dose of intravenous amoxicillin and clavulanic acid is recommended following assisted vaginal birth. Now, the important point is it is following assisted vaginal birth. It is not to be given prior to delivery, because giving it prior to delivery predisposes the baby to necrotizing enterocolitis. So it is to be given following AVD, as it significantly reduces confirmed or suspected maternal infection compared to placebo. And in all cases, we must follow good standards of hygiene and aseptic techniques as recommended. Postpartum bladder care is very important in these cases. We need to educate the women regarding the risk of urinary retention, and they should be encouraged to void urine regularly and not to hold it as long as possible. So timing and volume of first void urine should be monitored and documented. A post-void residual should be measured if we are suspecting urine retention. And women who receive regional analgesia for assisted vaginal delivery should have an indwelling catheter in situ for at least 6 to 12 hours after delivery to prevent covert urinary retention. And all of these women should be offered physiotherapy-directed strategies to reduce risk of urinary incontinence at 3 months, because that is very common following instrumental vaginal delivery. Complications, I think we all know: maternal vulval trauma, cervical trauma, obstetric anal sphincter injury, postpartum hemorrhage, which may be traumatic or it may be atonic, bladder or bowel incontinence, and very rarely maternal death. Perinatal, again, some are more common with vacuum, some are more common with forceps. Overall, they are all quite rare. Cephalohematoma, facial or scalp lacerations, retinal hemorrhage, jaundice, subgaleal hemorrhage, intracranial hemorrhage, cervical spine injury, facial nerve palsy. But again, remember, most complications are when a selection of cases is not correct and excessive traction is applied. For future pregnancies following this assisted vaginal delivery, we must counsel the women that there's a high probability of a spontaneous vaginal birth in subsequent labors. This was an innovation which I came across, which is an attempt to make instrumental vaginal delivery safer. An Odon device has been developed as a low-cost instrument, and WHO is implementing a 3-phase study protocol, but it has not yet been fully evaluated, so it cannot be recommended for routine use. So to optimize outcomes in assisted vaginal delivery, training of medical students is very important. They must be trained on models and later on patients, because unless they are trained, they are not going to be able to perform it later on in practice. We must abandon the procedure if there's no progress. We must avoid prolonged traction and use of excessive force. Following guidelines is very important, taking informed consent, ensuring asepsis, and a good post-delivery care. So AVD has a definite position in modern obstetrics. The trend to prefer Ventouse is seen worldwide, though there's no compelling evidence to support it. And preserving forceps as a choice for operative vaginal delivery is important, and that is the reason that postgraduates must be trained in application of forceps during residency. Thank you so much.
Thank you, Anju, for your excellent talk. This is very crisp, and you have covered all aspects from the incidents to the procedure, indication, forceps, Ventouse, and complication also, and what is the new era and what the guideline says. So you have covered all aspects. It was an excellent talk.
Thank you, Anju. You have really done justice to your topic. And a thorough academician is so nice to hear from you, a real teacher. And you have taken a very important topic. Thank you so much.
Thank you so much.
So I thank the organizers for involving me here. Thank you, Dr. Anju, for the excellent talk. It was like a revision for all of us and some new things also added on, like the Odone device. Thank you. And Dr. Patel, thank you so much for inviting us, for holding this seminar for our society. Dr. Asha, Dr. Rekha, all of you, thank you so much, and best wishes for all those who are going in for some elections. Thank you so much.
Thank you.
Thank you. Thank you again, Dr. MC Patel, Dr. Asha, and Dr. Preeti. Not only thank you, my best wishes to you also.
Thank you, ma'am. Thank you
for
so much.
involving.
Just one question, sir. Can I ask Dr. Anju?
Oh, yes.
For occipito-posterior, Dr. Anju, I really want to have your opinion. For occipito-posterior positions, vacuum or forceps, which would be an ideal this thing? Just wanted to have your this thing.
Anju?
Ji, ma'am.
Answer.
Actually, it will depend more on the operator experience, whatever the operator is comfortable in. I'm more comfortable with forceps, so I would prefer to use forceps.
We have used forceps, so we are more comfortable.
Can
with
I
the
add,
forceps.
Preeti, here?
Yes, ma'am. Yes, ma'am.
In occipito-posterior, the head is not fully flexed.
Yes,
in this
yes.
condition, the Ventouse would be difficult. That's why we use longer forceps to hold the deflexed head. That's why the forceps is more easier than the Ventouse.
Okay, thank you, ma'am. Thank you so much.
Now is the NFHS 5 data. Probably it says that institutional delivery has increased from 70 to 91%.
Almost 80% they quote, ma'am. Almost 80%.
So
80 to 85%.
Really
yes.
wonderful.
Yes,
So I
80 to
always say that this is good, and my passion to contraception should increase, and it has increased. There's no doubt about it. In some hospitals, it is, some states it is 74%. So wonderful lecture, wonderful talk, and as always, claps.
Thank you, ma'am.
Yeah.
And
Anju ji,
ma'am,
talk
yes,
was really
the
very good.
institutional delivery has increased, but many times the women come late in second stage or at the end of
So
first
that
stage.
is different, but they are delivering at the institute. That is different.
So they
that does
often
not
come
mean,
with the rupture.
yeah, that is different, but they are delivering in the institute.
अरे हमने तो इतनी forceps लगाई हैं कि बाप रे।
मैडम हम लोग ज्यादा यूज टू है फॉर्सेप्स के, क्योंकि जिस समय हम लोग ने करा था उस समय फॉर्सेप्स ही था। तो
और हम लोगों ने तो हाई वाली भी लगाई है एक्चुअली, जो नहीं लगनी चाहिए थी पर लगाई है, और मतलब ऐसा बहुत ज्यादा कोई कॉम्प्लिकेशंस भी नहीं। वेंटूज का कम।
Anju, mid cavity is very well used in the UK. They are using mid cavity forceps very well, the long forceps which are being kept as a specimen
अरे,
to carve this thing, but they are using it. I have seen them using
but
it.
यहाँ
So
तो
now
बहुत से
in UK
हॉस्पिटल
का
में है ही
highest
नहीं
rate
for
है. They will
such.
discourage the C-section like anything.
Patel sir,
But if you see the consent when they take for the C-section, they'll say it can lead to atonic PPH and it can lead to the maternal death. Who is going to give a consent for the C-section when they hear this? So it's really wonderful to see how they work.
So I will cover
बिल्कुल
this.
ठीक है, but we are working in this institution. Sometimes it is very difficult to counsel the patient. Now the patients are mentally prepared to come for the cesarean section. But
I
we
think,
have
ma'am,
to.
we can
Here,
have this
because of the
discussion
population,
again
the
at
load
the
is too
end.
much.
We
Here,
will-
because of the population, the load is too much.
Madam, we
Due
will cover
regards,
all
I
this
think
in
we
the
need
next
to start
webinar.
the
Organized sector,
panel
we are
now.
getting organized, and I'm sure in the coming times we are going to be as good as they are.
With due permission, I would like to please start the panel. Thank you, Dr. Anju, for that excellent lecture. I hope all my panelists are here. And the panel is going to be on a reverse panel on assisted birth. We've heard what assisted birth can do. And now we are going to see how it can land us in problems and how it can also protect us from problems. So, MC Patel sir, may I start?
Yes, we can start.
So now I would like to officially introduce MC Patel sir, who's a consultant obstetrician gynecologist and medical legal counselor. He was VP Foxy 2018. He has organized a number of conferences. As I make everybody's CV short, I would like to say that he is going for president next year. Also, he's been working for 21 years in the Northeast, holding camps, helping poor patients get appropriate health care. And this is something that people don't really know about. There have been many conferences, SOGO, AICOG. He is the go-to person in case of any medical legal problems. So also he is the brainchild of this whole program. Our next expert is Professor Uma Singh ma'am, a very respected dear senior who's a senior technical director, University of Manitoba, and ex-HOD and Dean KGMC, a very ardent person who will work on gynec oncology. I think first time I attended a conference in KGMC, it was for colposcopy, and she was the one who was in charge. So she is here now, and I would take the program further and request everyone to have, that's me. I've been introduced in short. I would like to invite everyone to see this video of Patel sir.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together, on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxyian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So we have our webinar on legal issues in assisted birth. I will be introducing the panelists as they come along in the questions. I think this question has been answered, but from the medico-legal perspective, I would still like to ask, sir, what is an assisted birth? And can an uncomplicated, good outcome birth also cause medico-legal problems?
So, what is an assisted birth? I mentioned during my welcome speech also. So, usually, whenever any vaginal birth without any assistance, no, induction of labor, no augmentation, no episiotomy, no tear to be repaired, then we call it as a very normal, natural vaginal birth. But any assistance when we give, whether it is induction, whether it is augmentation, whether it is instrumentation, whether it is episiotomy, so it becomes a assisted birth. And one second question, can an uncomplicated good outcome birth also cause medico-legal problem? Because there is no definition of dissatisfaction. Patient and patient party may be dissatisfied with our approach. Even if there is a good outcome without any complication, then also they can prefer litigation. But in this type of situation, burden of proof is always on shoulder of applicant. So patient or patient party, they will have to prove whichever allegation they put against us. And it is very difficult in this type of situation when outcome is good, outcome is normal, natural, or without any much problem. So these are the cases, are good cases to fight in court of law.
Thank you, sir. Now, I call in my panelists. We have Dr. Usha Sharma, ma'am, who is the Vice President of Hapur Society. Sorry, ma'am, for that mistake in the first flyer. And she loves reading and she also loves to do social work. She promised to share some photos with me, but she didn't. So over to you, ma'am. Dr. Usha Sharma, ma'am. I don't see her here.
So if
She
she's
is
not there,
Uma Sharma.
Yeah, Uma Sharma.
Not Usha.
Uma Sharma. Is she there? If she is not there, anybody from Hapur can take. Or anybody can take, no issue.
Hello.
Yes, welcome.
Hello, sir. Good evening.
Good
To all
evening.
the dignitaries and my colleagues. First of all, I want to give the opportunity to be the part of this platform.
मैम वुड आप अपना वो चालू करेंगे क्या? वीडियो चालू करिए ना प्लीज. आवाज नहीं आ रही है आपकी. नीता जी आप सामने दिख रही हैं. वुड यू माइंड टेकिंग दिस?
No, I will talk to Dr. Uma. Why she's not visible?
अरे भैया ये हटाओ दो हाथ में पकड़ दो
हेलो.
कोई
हेलो.
बोली
हेलो.
जी मैम बोलिए.
हाँ. Good evening. And first of all, I thank all the organizers for giving me the platform. It is a need of time to discuss the medico-legal issues of the assisted vaginal deliveries because after Consumer Protection Act in 1986 and the Supreme Court of India added the medical professionals under this, the medico-legal cases against the doctors are triggered now. People are filing legal cases against the doctors and are successful in establishing doctors are guilty and getting the compensation. Moreover, medical legal issues are much more for the obstetricians because they believe that the delivery is a normal physiological process and any deviation from the normal is considered to be the abnormal. This discussion is important to discuss to
Yes.
improve the duty of care, to
Yes.
help us to correct the any breach of duty. Lastly, to help us to deal with the unavoidable circumstances of the maternal and fetal morbidity in future to prevent them. Moreover, this discussion is very important because we learn with each other's experiences. Thank you, ma'am.
So, rightly said, as far as this discussion of assisted vaginal delivery or so and legal implications are concerned, if we go with statistic of United States, then 78% gynecologists are sued in their lifetime at least once. And out of those, 37% gynecologists are sued more than 3 times. And if you go with statistic of India, then medico-legal litigations are increasing in number constantly and steadily, and gynecologists rank first as far as litigation part is concerned. Gynecologists rank first, and that is why it is very much important for us to know which are the medico-legal implications in this type of situation. And it is very common and clear thing, because as far as this medico-legal problems are concerned, in assisted delivery or so, or any normal labor or so, people consider it as a physiological procedure rather than pathological procedure. And usually this type of patients they are not mentally prepared to accept this. And as far as any abnormal fetal outcome is concerned, with any morbidity or liability which is permanent one, then these are the potential cases as far as litigations are concerned. And that is why we have to know which are the implications and how we should be prepared to face it, and which precaution we should take not to end up into this kind of litigation in future.
Yeah. And I think I would just like to add here,
Yes.
if I
Yes.
may, now that you've put me as expert, that,
Yes.
for assisted birth, an obstetrician is a dilemma. See, why the obstetrician goes for assisted birth, offering assisted birth is basically to decrease the incidence of cesarean section and thereby avoid the complications now and future for the mother. She does it in good faith, in spite of knowing very well that skill-wise, most of the assisted birth procedures are more difficult. However, in spite of explaining all complications, even a smallest thing going wrong lead to challenges. And that's the reason why often they start avoiding assisted birth, offering assisted birth. Because we all know giving assisted birth is definitely more challenging. And hence, all those doctors who continue to work in good faith to decrease the incidence of cesarean section, this aspect must be discussed so they are well versed that just in case something what they did in good faith calls for some medico-legal challenge, they should be well equipped for it.
Yes.
Thank you, Dr. MC Patel.
Yes, very rightly covered, Uma Singh madam.
Genuine.
So, not to cut short, incidence of cesarean section only, but many times, say for example, head is at perineum, and we have noticed asphyxia to the baby. Then to deliver that very baby quickly, we have to assist or we have to go for any intervention. So in this type of situation, whenever we go for any assistance to that very process of labor, it is always considered in court of law that we have taken utmost care to prevent any morbidity or any another unwanted outcome as far as fetus is concerned or mother is concerned. So that is why it is very much important.
Thank you, sir. Dr. Manjula Pandey is not here. उनके घर पे सुंदर कांड हो रहा है. So I would request somebody to take this question. Or sir, I can read it to you. Why are litigations common in assisted birth?
It is very common because usually these group of patients are young patients and they usually come on foot in our hospital. चलते पैदल ही आएंगे. Of course, in very few conditions they are brought in ambulance or in an emergency. Otherwise, usually this type of patient comes on foot. Many times these patients are booked patients. Of course, a few patients could be unbooked also. And when they are booked patients, they expect from us all the favorable outcome. And naturally, we are dealing with two lives, mother as well as fetus. So this is also one more reason as far as litigation in assisted birth part is concerned. And patients and relatives are not mentally prepared to accept any adverse outcome because they consider it a physiology. Birth is a physiology they consider, and they never consider it as a pathology. Say, for example, if patient is having PIH or GDM, then also they will consider once we are here in hospital, all the responsibility will be of doctor and that very hospital. So these are the reasons why litigations related to this birth or assisted birth is concerned.
Thank you, sir.
Yes.
So now we have Dr. Amita Pandey, ma'am. So these are the common allegations for litigation.
Very good evening, my dear respected seniors and friends. And thank you, Dr. Patel, for giving me this wonderful opportunity. Now that we are talking about assisted vaginal deliveries and the litigations associated with this, I would request you to point out what are the areas for litigation, which we commonly get to see in our day-to-day practice.
Yes. So the common allegation in this type of situation are usually delayed in diagnosis or investigation and delayed treatment, wrong diagnosis, no consent, staff not qualified and delivery conducted by unqualified staff, infrastructure issues, unnecessary investigation. Many times we have to subject patient for certain investigation in that very given situation. But this is also one common allegation as far as this litigation are concerned. Emergency services not rendered properly is also one more litigation. When patient is brought, patient is in labor and in small nursing home, staff on duty examine patient, then he or she will call doctor and doctor will come. So some time is taken in this situation. So these are also one area as far as litigation part is concerned. Delayed in transfer, if we have to transfer patient for some region to higher center, then many times this is also one more allegation, delayed in transfer as far as litigation part is concerned. And congenital anomalies, whether it is fetal congenital anomalies which are undetected prior, and when baby delivers with anomaly is also one area, or when baby delivers with asphyxia or any other birth injury like cerebral palsy or so. So in this type of situation, these are the areas. So morbidity, and in very few cases, perinatal death is also could be the reason for litigation. Same way, morbidity or mortality on part of maternal side is also. And in few of the condition, one more allegation could be exorbitant charge against unexpected result, because patients and relative are expecting some good outcome. And if something goes wrong, and these are the areas as far as litigation part is concerned. And many a times, this is also more allegation, improper diagnosis of fetal distress, improper reading of CTG, improper or application of instrument like ventuge or forceps, and injuries related to that. Many times injury during cesarean section, say for example at the time of opening uterus, and small cuts could be on body of fetus. These are some areas where litigation could be there. And very common allegation, many a times, of course, we are in a tight situation that way. If we go for cesarean section, media is very keen or ready to bombard that rate of cesarean section is increasing and unnecessary cesarean section is done. And at the same time, on other hand, in court of law, very common allegation is there. You didn't take decision to go for cesarean section well in time, which led to this problem. So we have to take decision well in time, whatever intervention we are advising.
Thank you, sir. Now we have Dr. Nidhi Johari, who's the secretary of Lucknow Society, and her hobby is singing. So over to you, Dr. Nidhi. Nidhi, ma'am.
Anybody from Lucknow can take, no issue.
Can I read it, sir?
Oh, yes. Oh, yes.
Thank you, sir, for giving me this opportunity and the organizing committee. Which are the assisted obstetric situations which may lead to litigations?
There are so many obstetric situations, but usually, of course, external cephalic version nowadays anybody performs, or I do not know, but internal pudilic version, vacuum delivery, forceps delivery, and in this situation, failure of procedure, failed forceps, we can say, and birth injury related to that very procedure is also one of the cause. Hemorrhage after, say, for example, ventilation or vacuum or forceps delivery, if there is hemorrhage, then infection, then complication of anesthesia, if we have gone with some anesthesia, epidural or any other, and of course, when we have taken for cesarean section related issues. And in some of the condition, of course, we usually do not many times go for that also. If there is a big hydrocephalus and baby is SB, naturally to avoid cesarean section or so, we may go for craniotomy also. So this is also one more area. If we do not explain properly, then it may lead to litigation. Birth injury, any birth injury to the fetus and to the mother are also areas for litigation. Birth asphyxia and infection to baby is also one more area as far as litigation is concerned. Yes, Uma Singh madam can add, huh? You are expert. Yes, Uma Singh madam.
I agree. I am expert, but usually your expertise in these areas is so great that yes, when I have any comments to add, I will definitely do so.
But I enumerate all these situations where we may end up into litigation. But if any situation you want to add, you can add.
Yes, I would. I would.
Okay.
Thank you.
Ma'am, you have muted yourself.
Asha madam.
So welcome Dr. Manisha Jain, President Muradabad. She loves playing the keyboard, driving and travel. And these are the pictures that you can see of her travels. She with her family, kids, and the background so good. So over to you, Dr. Manisha.
Good evening, ma'am. Thank you. Am I audible?
Yes.
Yeah. Good evening, sir. Sir, it's my pleasure to be here. Sir, I just wanted to ask that kindly discuss the birth injuries and litigations associated to it.
So it is a very common area as far as litigation part is concerned, where we encounter any birth injury. And as far as maternal part is concerned, obstetric anal sphincter injury or perineal lacerations, hematoma, or cervical tear, paraurethral tear, then VVF, RVF, rupture of uterus, whether it is repairable or whether it is not repairable, and ultimately we have to go for hysterectomy. As far as fetal part is concerned, fetal asphyxia, Kifel hematoma, fracture of bone, clavicle or skull, skull or long bone. This is also one very common area is herb palsy or cerebral palsy we may call. It is also one area, and complication related to breech delivery, because whenever we are assisting any patient for breech delivery and something goes wrong with fetus, then it could be one area as far as litigation is concerned. And just I mentioned prior also, any sharp cut on body of fetus during cesarean section is also one more area. And perinatal fetal death is also a very common area as far as litigation is concerned. And just I mentioned prior also, when any fetal abnormal outcome which has permanent liability, these are the areas as far as litigation is concerned. Yes.
Thank you, sir. Thank you. Now you can have a look at this beauty. Dr. Dipali Verma, ma'am, who loves dancing, plays badminton as well. So over to you, Dipali, ma'am.
Good evening, respected sir and every learned speaker present over here. Am I audible, ma'am?
Yes, yes, you are audible.
Yes.
Sir, my question is, what is negligence? That is a harsh word to be applied on doctors, and what is exactly negligence
So
called?
in our curriculum of forensic medicine, we were taught two words: act of omission and act of commission. So as far as act of omission is concerned, something means not to do something which reasonable prudent doctor would do. Say for example, if patient comes to you to have injection of penicillin, naturally any prudent doctor would go to have a test dose, and if it is negative test dose, then only he will give full dose of penicillin. So it is an act of omission if you give injection penicillin full dose without doing any negative test dose. Same way, act of commission. That means doing something which a reasonable prudent doctor would not do. Say for if it is a planned surgery, it is not at all an emergency surgery, and it is to be done in general anesthesia, and if patient has come with full stomach. So in this situation, any prudent anesthesiologist would not go with general anesthesia. And if one goes with general anesthesia, then it becomes a case of commission and it is a negligence. And as far as negligence is concerned, to define it in a better way, whenever any patient enters in your clinic and once you accept her to treat, it becomes a contract or implied contract in eye of law between patient and yourself. You are offering your expert services, patient pays for that, or patient promises to pay for that. So once this contract is applied, once you accept any patient to treat, so legal duty starts from that very point of time once you accept any patient to treat. So if at all there is breach of that very legal duty by any means, then it becomes a one more ingredient of negligence. And due to that, any damage suffered by patient. So legal duty, breach of that duty, and damage suffered by patient due to breach of that duty. And very important point, that action of doctor should be proximate and direct to that very injury. So if these four ingredients are proved in court of law, it is proved that doctor was negligent. And in this situation, patient may have damage. It could be physical, it could be psychological, it could be financial also. So these are the ingredients as far as negligence is concerned. But these are much more interested as far as this is legal part. We have not to worry for that.
Okay, thank you, sir.
Yes.
Now we have Dr. Megha Gupta. Her hobbies are dancing and traveling. And before she starts speaking, these are her pictures. Dancing, traveling. Over to you, Dr. Megha.
Thank you, ma'am. Thank you, sir, for giving me the opportunity to be a part of this program. So today's lecture, it is very important in today's scenario, especially for the young gynecologists like me, who have a fear in mind regarding the instrumental delivery and the legal issue. So, sir, my question is, like, consent is very important if we see in case of instrumental deliveries and the cesarean section. Is consent important for normal labor also?
Yes. So very important question, because usually in our country, consent for normal labor is not routine procedure, but it is always advisable, because we never know. Labor may end up into any instrumental assistance or any birth injury, which we discussed prior also. So in this type of situation, at the time of admitting patient, or if it is your book patient, then before you should explain everything related to how labor can progress, how instrumental assistance may be required, how operative delivery may be required, how cesarean section could be required. So if it is explained, and if patient has signed that very document, which may call it as a consent, then it becomes a very important document and a very good defense in our favor. Because we never know. Say, for example, if patient is progressing very normally for normal labor, and if she ended into complete perineal tear, which may call it third-degree perineal tear or so, and we have to go for repair of that very tear. So if we have taken consent for the same prior, then it becomes a good defense in our favor. So consent for normal labor is also equally important. Many a time, there could be argument on part of prosecution that when consent was taken, patient was in a labor pain. So consent given in agony of labor pain cannot be considered as a valid or free consent. So if we have explained everything prior, before admission even, during our routine antenatal visit, it is always welcome in court of law. And if we take consent at the time of admission, then also it will do. And I would like to mention, it is available on Foxy website. If you visit Foxy website, under title of Foxy Uniform Consent, we three medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consent. And in that very consent, we have prepared consent for normal labor also. And we have prepared that very consent. If you go through that very consent, you will appreciate. We have prepared that very consent in a very simple language, which usually lay people may talk or lay people may understand. So that very consent for normal labor, if you take, it will be always beneficial to you in your.
I would just like to add here, Dr. Patel, probably correct me if I'm wrong, that what you know, when you explain all the possible complications when you are taking a labor delivery consent, it is very, very important. But we must remember, suppose just in case a complete perineal tear occurs and you have to repair it, then you have to again take a consent for repairing. For specific procedure, you have to take a consent.
No, you are absolutely right. But if you have taken consent beforehand.
Yes, of course, of course. No, I just wanted to add this on, that we should not think that by taking that full consent information, we have covered the consent for the complication, procedure. That we must remember, that we have to again go back, explain that this complication has occurred and explain what we are going to do. So that consent would be additionally required.
Yes, exactly. So if we have taken consent at the time of admission, and if we have mentioned in that very consent about this possibility of any tear, whether it could be simple laceration or perineal tear or in third degree perineal tear, or which may call it complete perineal tear. And in this situation, we would have to go for repair under anesthesia. And for that very repair, patient has already given consent, then separate consent is not required. But if we have not mentioned that it is always advisable to go for separate consent at the time of taking a patient for repair. If we are going for that very consent under whichever anesthesia,
Sir, can I
general
ask one
anesthesia
question, sir?
or spinal anesthesia, then we have to take separate consent. For
So, because when we take consent for labor, then we will enumerate all the complications, but we'll not do the detailing of all the complication management. So, once you are going for complication management, then you have to separately take the consent.
Very, very, very normal, very true.
Sir, can I ask one question?
Oh, yes.
Sir, but we are supposed to not take any consent on the table. But there are many complications which in normal delivery, like you said, CPT, complete perineal tear, which can happen. So is it possible that we can take it on the table when patient is conscious but in pain and bleeding?
But that is why I mentioned that it is already everything is included in that very consent which we have prepared, and it is available on Foxy.
We have downloaded and printed it, sir.
If you go with that very consent for normal labor, we have mentioned each and everything, even smaller point also we have mentioned that these are of course not so common, but it is not also uncommon. That way we have mentioned. So patient should not be scared also when you explain. Of course, we can explain like this is very, very less possibility, but it may happen. But if at all it may happen, then we will do accordingly or we will repair accordingly. So patient should be taken into confidence also, because patient should not be scared at the time of taking consent. And I would like to mention one very famous case of C. Jaipal Reddy versus Padmini Velluri, which was happened in Hyderabad. So at the time of deciding this case in National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign. It is a very important document of your counseling. Whatever you have counseled to that very patient related to your treatment plan or your management plan, whichever we call. So it is very important document. So whatever you have counseled, each and every point should be mentioned in that very paper. And when patient signs that very document, it becomes a consent. So when patient gives consent, it becomes a documentation. It is a good documentation. So whatever you counsel to the patient, it your communication. And once patient signs that very document, it is a documentation of your communication. So if we go like that in that very consent, then it becomes a very good defense in our favor whenever we are facing any litigation. Yes, next.
Thank you, sir. Now we have Dr. Neeta Sharma, who's the president of Hapur, and she enjoys traveling and generally enjoying life. So over to you, Dr. Neeta Sharma, ma'am.
Thank you, ma'am. Thank you. Good evening, sir, and all. Thank you, sir, for giving me this opportunity. Sir, my question is it expected to take a written consent for induction of labor?
Yes.
You have already discussed about the normal labor.
So as far as part written is concerned, if we go by law, then there are three conditions where written consent is very much mandatory. One is organ transplantation. Second is termination of pregnancy under MTP Act, and sonography of antenatal patient under PCPNDT Act. In all other conditions, we may go with oral consent also, but burden of proof is on your shoulder to prove in court of law that you had explained. And many a times in court of law, patient may go hostile and patient will say, we were never explained, we were never taken into confidence, we never gave any consent. So though it is not mandatory, it is always advisable to go for written consent. If for normal labor or for any operative delivery or any instrumental delivery, whichever intervention we are going to go for, but written consent is always advisable.
Thank you, sir.
Thank you, sir.
Yes.
Anybody wants to add something to this? These are the FOXI uniform consents. So you want to explain this a little?
In that very concern, Joe, if you see with this yellow marking and red, it may not be possible to predict beforehand whether intention will be needed or not. We have mentioned in that very concern, and we have prepared that all those consent in two parts. Part one is information and part two is undertaking. And in that very part one, that is information, we have subheading, almost 8 subheadings. Say, for example, name of procedure, meaning of procedure, indication of that very procedure. If we are going to go for ventouse or forceps, what is the indication of that very procedure? We have mentioned that also. Refusal. Many a time patient is not ready to give consent for forceps or ventouse. Then we have mentioned in that very consent which are the consequences of refusal of that very procedure. And we have mentioned other alternative. If patient is not ready to go for forceps, say for example, are other alternative available to the patient? We have mentioned that also, because we have prepared those consent with taking base of famous case of Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008. And in that very case, it was decided that what is ideal consent in Indian construct. And in that very case, all this guideline came up from Supreme Court, and in those guidelines, it is mentioned that consequences of refusal of consent should also be explained to the patient, and other alternative, whichever alternative you have advised, but other alternative should also be explained to the patient. And all the probable complications also we should mention at the time of explaining. So we have prepared those consent taking this base of this case, and in that very consent, everything we have mentioned.
Thank you, sir. And we have Dr. Deepshikha Goyal, ma'am, who's the secretary of HAPOD, and she does drawing and painting, sir. See, these are her paintings and drawings. So, welcome, Dr. Deepshikha. Over to you.
Thank you, ma'am. Good evening to all. And thanks for making me a part of this webinar. I want to ask, sir, as we all know that keeping records is very necessary. But what is the importance of record, and for which time? For how long time we can keep records? Like delivery ka record, hum kitne saal rakhe hain, DNC ka and OPDs ka. That is a questionable thing ki bhai, पूरा clear नहीं होता है हम लोगों को कभी-कभी.
Fine. So as far as importance of record is concerned, naturally, whatever you have done for patient, you can prove in court of law by record or documentation only. So records are always at your rescue. So all the records should be kept updated. What was done, nothing was neglected, and given treatment should be met fully with standard of demanded by ethics and law. And we have to prepare all those records as far as record part is concerned. And we have to mention everything, including partogram, CTGs, or any investigation we have advised during labor, because many times we have to go for some investigation during labor also. So whatever we have advised to the patient, whatever we have done for the patient, each and everything is to be mentioned in that very record. If we have involved our professional colleague for any assistance or any help, then it should also be mentioned. And it is to be written by that very person who has attended that very procedure or surgery or intervention. Say, for example, seen by Dr. So-and-so, his or her findings, or her advice, whatever she has advised, and advise, and that execution of that very advice, it should be reflected in your documentation. Say, for example, in nursing chart, say, if she has advised some investigation, then it should be mentioned in that very case paper that this investigation were advised to the patient on advice of Dr. So-and-so. So these are very important parts as far as records are concerned. And naturally, good record is good defense, poor record is poor defense, and no record is no defense. And it is my experience during my medical legal practice. We doctors are very poor as far as record keeping is concerned. We have had to examine patient very frequently, even during labor and antenatally when patient is waiting in a labor ward and not in active labor, then also we have habit to examine patient, but we have no habit to enter it into record. So during labor, we examine patients so many times. So make a habit to enter into record with date and time about, say, for example, pulse, blood pressure, temperature, oxygen saturation, fundal height, uterine contraction, fetal heart, descent, everything we have to mention. Then leaking, if ARM is done, then that also we have to mention. So whatever we do in good faith of patient, each and every part is to be recorded in that very record. And it shows your consent that you have taken utmost care of any patient in given situation, way in which any prudent gynecologist would have taken. So it shows your consent. So records are very much important and they are always at your rescue.
So I would just like to add, nowadays, with the era of lot of things available digitally only, very often the investigation reports are only on mobile phones, etc. So for every case, please take a printout, do appropriate signaturing and attach them in records. I know it takes time, it goes against, the paperless and all those things, but for document, these are very important. Also, it is a good idea that when some critical situation occurs, when people are very busy in giving that critical management, there should be one person dedicated to writing down the notes. And just in case, if you have to add those notes a little later on, be very, very careful about the handwriting, the pen being used, the sequence of those things, not doing overwriting, because, we don't realize we do it in good faith, but in court of law, all these things are picked up by lawyers and they, threadbare, they take out all possible negative things out of these. So please be very careful about critical situations record maintenance.
Excellent, Uma Singh madam. So you have very rightly pointed out. So whenever we receive any report of investigation on phone or so, but if we are maintaining record in our computer or so, we can add those report of investigation in that very computer. And if we have habit to go with prints, then we can have print of that very electronic reports, and we may attach to our case paper of the patient. So it is very much important, because whatever we have done for patient, we should have all the records with us to prove in court of law, because many times if this record is not available, then it will be considered by court that you never advised that very investigation. So whatever you have advised, whatever you have get it done, it should all be there to prove your case in court of law.
कितने समय के लिए सर हमको डिलीवरी का
रिकॉर्ड
प्रिजर्व करना चाहिए?
Dr. Deepshikha, we have a separate webinar on documentation. I will put the link in the group. Okay. And sir, we need to actually go forward. We've overshot our time and we still have 5 people to go.
Yes, welcome.
So we have Dr. Nutan Upadhyay, ma'am. She loves reading, and sir, in COVID, she started learning Kathak at this age. So hats off to her. And these are the images that she has of her dancing. And now she has reached 4th year, about to complete 4th year.
Good.
From Prayag University. So over to you, ma'am.
Greetings to dear MC Patel sir And Asha Jain ma'am, I would compliment you for giving such a multicolored introduction of each of the speakers. So the entire meeting is now monochromatic, but with lots of colors. So congratulations, ma'am. And sir, a very interesting webinar going on. As usual, you have putting in all the details. So my question is that, sir, since first year, we have been filling our discharge cards. I think as residents, that is the first step that is we do, start filling our discharge cards. With each year we keep on increasing and doing it. So but what is actually the importance of discharge card, especially in today's time, and how detailed or what are the specifications that we should never miss when we are stating the discharge details? So there are some things which should never be missed, and how are they going to help us back if we go back to them later?
Discharge card is one more document, or we can say mirror of our treatment plan, which we have offered or which we have given to the patient. So each and everything should be mentioned in that very discharge card, and it is expected from law and court also. So general information of patient, naturally it will be their name, age, address, etc., and provisional diagnosis. And if we have come to final diagnosis, then final diagnosis also we have to mention. All the operative note in a very brief. Say for example, if you have gone for cesarean section or vacuum or forceps or any intervention or any injuries and we have repaired, then that also should be mentioned. And all the investigation, if we cannot mention all the investigation in discharge card, then we have to mention that all the investigation done during the course of treatment are given to the patient. That very simple point should also be mentioned in discharge card with number. Say for example, 10 copies of investigation or 15 or whichever. And very important part, whenever we have encounter, say for example, complete perineal tear, so post treatment counseling is also equally important. So at the time of discharge, we have to mention that also, about care to be taken by patient, about diet, about medicine to be taken, about exercise, about dressing, about follow-up. And very important thing, if we have delivered premature baby, then we have to advise to go for opinion from ophthalmologist to rule out retinopathy due to prematurity. Because there are two decided cases against our doctor fraternity. One was happened in state of Tamil Nadu, and in that very case, it was preterm delivery. Baby was admitted in NICU. In due course, baby was discharged from NICU, but at the time of discharge or during the course of admission in NICU, parents were never explained. Parents were never advised to go for opinion from ophthalmologist, and in due course, that very baby went blind. Case was filed and compensation of 1.8 crore was awarded in favor of baby and her family. So, of course, it was happened in government hospital of Tamil Nadu. So, almost 1.73 crores were to be paid by Tamil Nadu government, and rest of the amount was to be paid by NICU doctors. In this very case, gynecologists were not made party, so gynecologist was lucky that way. And same type of case happened in state of Gujarat only. Very recently, patient was actually from Nandurbar, it is in Maharashtra, and patient had been to Bharuch for delivery. It was her first delivery and she had been to her maternal place. It was again a preterm delivery, and for 42 days, baby was admitted in NICU. And this long course of admission, during admission, parents were never advised to go for opinion from ophthalmologist. After discharge, after 2 or 3 days, patient had been to gynecologist with that very baby with complaint of watering from eye. And gynecologist at that juncture of time, she didn't advise to go for ophthalmology and she prescribed some eye drops. Then after patient had been to her in-laws place. But somebody advised them to go for opinion from ophthalmologist at Nandurbar, and they had been to Mumbai and ultimately in South India in Shankar Netralaya. But at that time, diagnosis came that she is having retinopathy due to prematurity, and that very baby will go blind within 1 month or so, and ultimately it happened. And case was filed. And in that very case also, compensation roughly about 90 lakhs is awarded in favor of that very baby and that family. But in that very case, I would like to mention that parents demanded record from that very hospital of treatment given, and hospital didn't give record to the patient, and for that excess amount of rupees 75,000 was awarded to the patient and patient party for not providing record from the hospital. So these two cases are very important case. It shows importance of instruction or guidance or advice at the time of discharge. Of course, during course of admission also we should be very vigilant to advise accordingly. But at the time of discharge, we have to advise about diet to be taken, exercise, medicine to be taken, follow-up, and any references like this, just ophthalmic opinion or so. So it is very much important.
Sir, any correlation of about the assisted deliveries that we mentioned in a card? And sometimes the child is maybe immediately child doesn't have asphyxia, but later on in 4 years, 5 years, any IQ things. So any correlations that we should take care about these things? Maybe because there are long studies now coming, maybe of later years and all. So anything that you would like to comment on that?
But if specific instruction is to be given, then naturally we have to give at the time of discharge only. But if anything happens after 4 or 5 years, then burden of proof is always on shoulder of prosecution. That is on patient and patient party to prove that whatever baby suffered after 4 years or 5 years, it was related to birth asphyxia or any other injury which happened at the course of delivery. So it will be on shoulder of patient and patient party to prove. But
Thank
we
you,
have
sir.
mentioned in discharge that it shows our consent. So because we are bona fide to show each and everything to the patient, and we are not hiding anything.
Thank you, sir.
Yes.
Thank you, sir.
So now we have Dr. Sabah Asad ma'am. She is the past president of Moradabad. Sabah ma'am, if you are there, would you please read your poem yourself? It would hardly take half a minute.
Yeah, I'm very much here. Good evening, everyone. And thank you so much, Dr. Patel, sir, and Dr. Asha, ma'am, for inviting me. And thank you so much for inviting me to recite my poem. Actually, मेरी ये जो poem है, my daughter is in class 2nd at that time, and there was a poem, if I were a apple, like this. So I just made this poem that if I were a plant and grew into a tree, I think I would be thankful to the lovely lady like me, who planted a little plant and gave me a better place to live in. With a tender love and care, my process of growth began. When I shall become a tall tree, I will see how glad she will feel that I am her tree. I would stay there, giving everybody shelter and comfort. She planted a beauty. I must be thankful for her wonderful effort. Plant a tree and add a new friend in your life.
Thank you, Dr. Sabah.
Thank
Thanks
you,
a
ma'am.
lot for that. And
So,
please show your
sir,
face. We
my
want to see your
question is,
video.
okay, ma'am. My question is, against whom complaint can be lodged?
As such, patient and patient party are free to lodge complaint against anybody. So, doctor on duty or specialist or nursing staff or any other staff, pharmacist, radiologist, sonologist. So, any medical service provider would be a person whom patient or patient party may go for complaint.
Okay. So one more question would like to ask,
yes.
apart from this question, that
Yes.
for how long should we keep the records, like indoor IPD records and OPD records?
So, as far as if we go by law, that according to law, as far as MTP cases are concerned, it is for 5 years we have to preserve. PNDT cases for 2 years, and with this newer ART Act for 10 years, and then after all the records are to be transferred to National Registry, and if it is a case of surrogacy, then for 25 years. So this is by law. By guideline on Medical Council of India, and now newer version, that is National Medical Commission. As far as OPD case papers are concerned, for 3 years, indoor case papers are for 5 years, and as far as this litigations part is concerned, patient may complain within 2 years of cause of action happened. But as far as our obstetric part is concerned, after attaining majority, baby may sue within 2 years. So we should preserve all the records related to our obstetric treatment at least for 20-21 years.
Okay. Thank you, sir. Thank you.
Thank you, sir. We have Kanchan Prasad ma'am, and this is her garden. She's a professor. So
thank you. Thank you so much, ma'am. And thank you, sir, for including me into this
flowers
webinar.
as fresh as you. There.
Thank you, ma'am. And I would like to ask the question to sir, where the patient can go for the complaint. That means where complaint can be lodged.
So there are various platforms. If patient is interested to go for compensation, then she has two options. They can go for civil suit, or they can prefer appeal under Consumer Protection Act in Consumer Fora. If they are interested to go for criminal case against doctor, then they can go in police station or in criminal courts for litigation. They may prefer appeal in some commission also, Human Rights Commission, Medical Council. They can prefer appeal in government also. With this newer Clinical Establishment Act, they can complain in Office of Chief Minister also, in Health Minister also, and in medical college. If they have any grievances against any doctor in medical college, then they can complain head of the unit, head of the department, head of the institution, and head of the, in health ministry also, they can go for complaint. So there are so many platforms where they may prefer appeal or they may prefer complaint.
Thank you, sir.
Thank you, sir. Now we have Rajul Tyagi ma'am. She's the president, Lucknow Private Gynecologist Forum, and her hobbies, she said, I love working. So she is a workaholic, as she said herself, and she loves sightseeing. So, over to you, ma'am.
Yeah, good evening, everyone. Thank you, Patel sir, for making me
Welcome,
part
ma'am.
of this such a prestigious and very informative panel. So my question is, can simultaneously complaint can be lodged at more than one places?
Yes. Yes, and no also, both the answer. But before that, Rajul Tyagi madam, welcome. You are good host, and whenever I had visited during your conference, warm welcome and hospitality extended to me. So thank you for the same.
Thank you, sir. Thank you for your
So
generous.
as far as simultaneous complaint is concerned, as far as compensation part is concerned, patient cannot go for simultaneous complaint in civil court and under CPA. They can go anywhere in one fora only, either civil court or CPA. But they can prefer complaint for compensation, say for example in CPA, and simultaneously they may go for complaint in criminal case also, in police station or in court of law. They may go simultaneously in Human Rights Commission, in Medical Council, in government. They can go simultaneously also, because now it has become habit of patient or patient party or advocate on part of patient. They will lodge complaint in more than 4, 5, 6 fora. Say for they will go for complaint in CPA for compensation, criminal case in police station, in Human Rights Commission, in Medical Council, in government. So we will have to face all these consequences wherever we receive notice from that very department. So patient is free to go for simultaneous complaint, but just I mentioned like that only.
Thank you, sir.
Thank you. Thank you for that.
Next, we have
informative
Dr.
answer.
Neelam Mishra, ma'am. And you can see her. She likes traveling. And over to you, ma'am. She likes reading as well.
थैंक यू MC Patel sir. आपकी तो इतने सारे टॉपिक्स हम लोगों ने सुना है. Maybe you are really making people's life easier by making us understand about the law, and कह सकते हैं सर कि हैमर करते हैं हम लोगों को बार बार कि लिखो लिखो लिखो, consents लो. It is very good on your part, because my HOD used to tell us that. हमारी ट्रेनिंग पीरियड में मैम हमारी my teacher was Dr. Neera Agarwal. I don't know whether you know her. She's from Delhi. She used to say कुछ भी करो, पहले लिखो फिर करो, करो फिर लिखो, but you do it. Sir, आप वैसे ही बिल्कुल हैमर करते हैं. Thank you for that. And Dr. Asha Jain ma'am also for making this program such a success. So my question is there any time bar for registering a complaint or filing a case?
Yes. As far as CPA part is concerned, for compensation, limit is for 2 years. Patient will have to file complaint within 2 years of cause of action happened. But I would like to put one example. Say, for example, mop left inside abdomen. So operation done in 2024, but patient comes to know in 2030. So from that very time up to 2 years, she can lodge a complaint. So cause of action came to knowledge of that very patient, she can go for complaint. If she has crossed that very limit, and if she can convince court for delay, why complaint was not done in time, that is within 2 years, then court may condone the delay and entertain complaint. So this is for CPA part, that is compensation part. But as far as criminal cases are part, there is no limit. Patient may complain as far as criminal complaint is concerned against anybody at any time. There is no time limit, no time bar as far as criminal cases are concerned.
Sir, am I allowed to ask a question?
Yes.
Sir, as per rules, you don't keep the records more than 5 years, right?
Yes.
Now, some patient has made a criminal complaint against you after 15 years.
Yes.
You don't remember who that patient is. You have no records. Now, what do you do?
Yes. So in this situation, at the time of destroying record, there is a procedure of destroying record also.
No,
You will
agreed. We followed that procedure. Everything is done.
I am coming to that.
Yes,
So
sir.
you will have to give advertisement in 2 newspapers, one in English and one in vernacular language, that we are going to destroy record from this date to this date. So any eligible person who is interested to get that very record are requested to contact hospital in office hours or whichever time we give till this date. After that very date, all the records will be destroyed and hospital will not be responsible for the same. If we have done this, and if we are facing litigation after 15 years or any n number of years, then we can say in court of law that under MTP Act, we were supposed to preserve record for 5 years only, and we have destroyed all the records. If patient is having any record related to that very treatment given by us, it should be given to us through court from patient. If patient can give, then from that very record we can argue or we can clear our stand. If there is no record available, then court may take cognizance for the same and you may be free out of that very allegation.
Thank you, sir. Sir, anybody wants to take the cases or should we end? So
apart from taking
the basic
cases,
thing in the first case was, what is the importance of time in consent?
so
So
just a moment,
so
Asha.
it is in
Just
time
now,
consent. We should take consent in time.
yeah. So about, how when to keep the records, till when to keep records. A little while ago, Dr. MC Patel himself said that, it is wise to keep your obstetric case records, for a longer period, even though officially it is said that you can destroy them earlier, because whatsoever, you give it in newspaper, they may bring some their own documents which they have. You would be at a better footing if you have your own records. So he mentioned that, and at that time also it struck me that yes, for an obstetrician, perhaps it is prudent to maintain his records for a little longer time to save his or own skin. I do remember he himself said about 20 to 25 years, because nowadays late complaints are being lodged where people later on, for fickle things, they say delivery was the responsible factor.
Yes.
So I think it is a wise investment. If not all paper records, then maybe you can digitize them and keep them. I think that would also be useful if you digitize them properly and you keep them. What do you say about digitizing those records for a longer, this thing?
It is always fine, but as far as destroy of record is concerned, you cannot destroy record before that very period you are supposed to keep. Say for example,
beyond that.
Beyond that it's fine. And if it is available on with computer or so, it is always better to keep all the record. But in this situation also, if we have published that we are going to destroy that record, and if we have not destroyed, and if it is with us, then if it is in our favor, then we can say in court of law, yes, these are the record, and we have treated that very patient as per standard medical norms, etc. If from record, if we feel that it goes against us, then we can also take that ground also, that we have already destroyed those records as per.
That's a very wise thing. That's becoming street smart.
Yes.
Wow.
So if you have preserved all the records, it is not necessary to say in court, yes, still we have all the records. We will go through that very record, and as per the facts of the case is concerned, if it is in our favor, it is always better to produce all those records in court of law.
So, sir, any other questions by the panelists? Anyone wants to ask anything before we actually end the session?
Yes, I want to ask one question.
Yes.
Yeah, please proceed, ma'am.
I am doing IVF. So basically what happens that patient gets their IVF done and they divorce after 2 years or 3 years. And then the wife will come separately to ask for the paper, or husband will come separately to ask for the paper. And they have been given all the papers. So how should we give them paper just because they are asking it again, or should the law, they should come through the law to get those papers?
It is very clear. If patient
so they are applying for divorce on the ground only. She cannot produce a child, or he cannot produce a child.
I got your question.
Yeah.
So if that very document is signed by patient only, then you cannot give that very record to her husband also without permission of that very patient. If both have signed the document, say for example, in so many ART procedure, usually we go with signature of both husband and wife, then both are entitled to get record from your hospital.
Thank you, sir.
But any other person, not husband, not wife, any other relative, you can refuse, because without permission of patient or her husband, you cannot give any record to anybody, because it becomes a breach of confidentiality.
So even if it is by lawyer, if he is
even by lawyer, if there is no consent letter from that very patient that I have given my authority to collect record to my advocate, then you can give to her advocate. Otherwise, straightway, if advocate comes to you, then you cannot. Say, for example, many times insurance company people comes to you to collect some information or some record of that very patient. So in this situation also, if patient has not permitted, if patient has not given you permission, you cannot give record to that insurance company people also.
Yeah, and I think it is very important.
Yes.
Remember, apart from certain conditions, it is the woman who is our client.
Yes, exactly.
So it is the primary this thing of the woman, except certain procedures like Dr. Patel mentioned related to IVF, etc., where both parties are involved. So it is the woman and she has the primary right over her records. This is very
Ligation also, I don't know whether the both husband and
no,
wife
not
has-
both. For
No, no.
ligation, only the woman is our client.
Client. Okay. Thank you, sir. Thank you, ma'am.
Any other questions?
So, Asha, I think I would just use this opportunity. It has been great to be an expert for namesake, but have utilized this opportunity to learn a lot of things. Dr. MC Patel's, kind of expertise in this area is beyond doubt. So excellent that it always helps to be part of these webinars. Thank you, Dr. Patel.
Madam, thank you for the same. And I had requested for this only. When I talk to you, you should be with me as an expert one. So if any clinical part is to be taken care of, then you would be at my assistance. That is why I had requested you. And you have justified my invitation. Thank you for the same.
Thank you so much,
And
Dr.
finally, my personal appeal to endorse my candidature for post of President Foxy year 2024, and this is for presidential year 2026. So if you consider my seniority, my sincerity, my dedication, and readily available to be helpful to any of our Foxian friends, then please endorse my candidature and please vote for me. Election would be in month of August from 1st to 10. There are more than 28,000 voters. To call each and every voter is not possible. So not taking that part that Dr. MC Patel didn't personally call or personally had a contact, please endorse my candidature and please help.
Sure, sir, sure. You are a very well-deserving candidate. So you, and best of luck from our side.
Thank you. And
My
same way,
request
Asha.
as well to support me for chairperson.
Oh, sure, Asha. Don't worry. Yeah,
And same way, Preeti
all
Kumar
are
also-
with you.
Preeti Kumar is also for post of Vice President North Zone. So we have to support her candidature also to nominate in month of May and to vote in month of August.
Thank you, Dr. Patel, for the opportunity, and it was really wonderful. I have listened today. I am free.
It is our
so
pleasure.
I
Yashodhara
could
madam
remain
is
the
still
whole
there
time.
up to end. So it is our pleasure and it is our honor rather.
Yes, sir.
Yashodhara
I
ma'am,
will
would you like to say something? Jaiswar ma'am, Yashodhara
Thank you so
ma'am.
much. Thank you so much. It was really very learned because I knew that you are the best medical legal person in the
Dr. Asha,
in India.
really, it was a
But
wonderful.
after a long time, I heard the whole story. Thank you so much.
And Dr. Asha and Dr. Patel, you have chosen very well, very good topic. As we know
Very
now,
good questions.
day to day, we have lots of medical legal problem. As Dr. Uma Singh is also knowing that we are still struggling with the case which was done in 1990. She delivered in 1990, and still we are going to face court tomorrow. Tomorrow, our team is going for that. So that in that situation, definitely, but it's very difficult to keep records for so long, especially case sheet. It is a very difficult to keep. But once with the court asks these things, we have to collect either from our register or case sheet, whatever it is. It was a thank you so much, and my best wishes to all of you, Dr. Patel, Dr. Asha, and Apriti also. Best wishes. Thank you so much.
Thank you, ma'am. Thank you.
Thank you. Geeta Khanna ma'am was also here. So if she wanted to say something. Otherwise, it is my pleasant duty to thank everyone who's here. So, first of all, thank you, MC Patel, sir. Thank you, Jaiswar ma'am. Thank you, Yashodhara ma'am. Thank you, Chandravati ma'am, Manju Shukla ma'am, Nisha, Dr. Nisha, Dr. Geeta Khanna, Dr. Anju Agrawal for the great lecture, and Dr. Uma Singh as the expert, all our panelists, I'm not taking each name separately, and Corona Remedies for being our academic partner and always being there till the last moment to correct things when they go wrong. So I also thank all the viewers who make the program worthwhile, so that, we have that will to do better for the next time. So thanks a lot. Thanks all of you for being here. Namaskar.
Thank you.
So
Namaskar.
suggestions and comments are always welcome to make our future program more interesting and more fruitful.
Thank you so much, sir. It was really a very wonderful.
And best wishes to all who are going for the post for the election.
Thank you,
because it is really wonderful to work in the Foxy. And I just finished my tenure, so
yes. We
you
have
can see that
also
I'm
seen
so
you
free.
working.
You can see that I'm so free today.
Yes, you are free. Yes.
So, and I must say that Asha made it definitely more charming and attractive by, adding that personal touch. Thank you, Asha, for that.
Thank you.
Nice
आपकी
touch.
embroidery का मैं इंतजार करते रह गई.
Yeah, I reached home late. I would sometimes give it to you. Definitely. Thank
You
you.
send it, I will use it next time.
Yeah, I would. Thank you, Asha.
Thank you, ma'am.
And good
thank
night,
you all.
everybody.
And should we
Asha.
conclude? Should we conclude?
Yes.
So good night to all. Thank you. Thank you very much.
Good night, sir. Good night, everyone. Good night.
Good night and namaskar.
Good night,
okay,
everyone.
ma'am.
Good night.
Oh, we can conclude.
Ma'am, can I end this session?
Oh, yes.
Yes,
Still
yes.
you can.
Okay, ma'am.